So I'm very excited to be here, and this is one of my favorite topics, not only to talk about, but primarily to treat my patients with regard to upper extremity nerve entrapments. I found when I was doing my studies and my training that a lot of surgeons are a little hesitant about seeing patients that have upper limb pain, because they feel that with upper limb pain, you never know what you're going to find. You're going to get all of these patients who really are just looking for more drugs and are not treatable, etc. But I find that that is not the case. If you meet a patient and you take the time to listen, you can quite often find both a diagnosis and a friend. And so it is my pleasure to share with you some of the thoughts that I have on the clinical examination and diagnosis of the upper extremity. So what I will be discussing today is the why behind why we should have a standardized clinical examination for the upper extremity nerve exam. The how do we perform the clinical examination? The when, what are some of the things we can expect to find, and when should we be doing this? And then finally, the most common of all, what are the diagnoses that I see or you see in your practice? Let's start with the why. Why should we even bother with having a standardized exam of nerves in the upper extremity? Well, the answer might be simple, but the answer is diagnosis. These are two books by a woman by the name of Lisa Sanders. Lisa is a physician who writes in a column for the New York Times, and she's even written a book that calls Every Patient Tells a Story, Medical Mysteries and the Art of Diagnosis. And I just love that word, the art of diagnosis, because that is what we do as surgeons and physicians. We perform the art of diagnosis. And this is what she has to say about finding a diagnosis.
Getting the right diagnosis is the most important thing you can do for a patient. You'll never get the treatment right if you don't have the right diagnosis. One of the tools that doctors use are the other doctors in the room. And whether you're going to get a diagnosis or not really depends on who's in that room and who might see something that they recognize and understand and then identify it.
Getting the diagnosis right is the most important thing you can do for your patient. If you don't get the diagnosis right, you'll never get the treatment right. So when it comes to upper extremity nerve pain or nerve examination, how do we determine the diagnosis? Well, in my practice, we use three simple triads. We use 1, muscle testing, 2, the scratch collapse, and 3, pain and or Tinel's test at the level of entrapment. So what's the rationale behind that? Well, we all know that if you look at the nerves of the brachial plexus at a root level, we find general motions of the upper extremity. So for the C5, we will have shoulder abduction and external rotation. C6, we will have shoulder adduction and flexion. C7, elbow and wrist extension. C8, wrist and finger flexion. And T1, finger AB and adduction. But we all know that most of the upper extremity nerve entrapments are peripheral and not found at a root level, meaning that if you have an axillary nerve problem, it's going to be C5, C6 root, radial C5 to T1, median C6 to T1, and ulnar C7 to T1. But when it comes to clinical testing today, a majority of us will use, for brachial plexus problems, muscle testing to look for root level or brachial plexus level. But when it comes to peripheral nerve entrapments, we primarily use sensory testing or provocative maneuvers that want to elicit sensory problems or disturbances. But we really need to remember that muscle testing is a key component to this, because peripheral nerves are both motor and sensory, so we need to bring the motor exam into testing for peripheral nerve entrapments. This is Seddon's grading of muscle strength. He presented this at the Medical Research Council in the UK in 1954. Sedence M0 through M3 entails an axonal injury of the nerve, whereas a grade 5 is a completely normal nerve or neuromuscular function. But what about sedence grade 4? Well, it is defined as contraction against gravity and slight resistance. Well, this is what you find when you have a nerve compression. This is what we like to call the hidden paresis. It is hidden because when your patient comes through the door, it's not going to be entirely evident. You are going to have to go and look for it. So in a majority of nerve compressions, you will actually not have an axonal injury to the nerve, but rather changes in the axonal transport. This means that when it comes to EMG or nerve conduction studies, they will have rather low specificity. If you look at nerve conduction studies of nerves proximal to the carpal tunnel, the specificity is between 30 to 70% for the median, ulnar, and radial nerves. This little cartoon that you see to the left is Dr. Electrophysiology, NCS EMG, as drawn by Lee Dellon in one of his publications in 1992. Dr. Dellon writes about Dr. Electrophysiology this multi-channel oscilloscope-faced tyrant conceals his empire building beneath a white lab coat. Reflex hammer and stethoscope are reminders of medicine's historic past, before the days of computer averaging, evoked potentials, and F&H waves. Have sufficient confidence in your clinical skills that your judgment, not Dr. Electrophysiology's printout report, will be the final authority. So the clinical skills that Dr. Lee Dellon is talking about is, among other things, muscle testing. In a blinded controlled study published by Jepsen and co-workers in 2018, they looked at using a standardized muscle testing algorithm for upper extremity nerve compressions. And what they found was that they had an 88% sensitivity and a 93% specificity. Susan McKinnon went on to describe the scratch collapse test. And she found that this has an 89% sensitivity in carpal tunnel and cubital tunnel syndromes. So based on this, we use a clinical triad. First, manual muscle testing. This is done in the standardized fashion to find specific patterns of muscle weakness distal to the level of nerve compression or affliction. So you use this first to delineate the level of nerve compression. Second, the scratch collapse test, where you look for ipsilateral weakness in external rotation after provoking the nerve where it is compressed. And finally, pain and/or a positive Chenel's test at the level of nerve compression. You may, of course, if you want to, add additional provocative maneuvers at this point. So let's look at the how. How do we perform this clinical examination? Well, let's start with the muscle testing. The muscle testing has 4 steps: the shoulder, the elbow, the wrist, and the hand. And this is a video of how I perform the standardized muscle testing exam in every patient with a suspected nerve compression. And there will be sound shortly. So remember, bilateral testing, always start with the shoulder. Patient is seated straight, firmly. Elbows straight, make a fist, a little bit closer. And resist as I push out, and resist. Perfect. You test the strength and pectoral. Side, resist as I push in. Testing the posterior deltoid. Move on to the elbow position. Elbows to the side. Resist as I push down. Test elbow flexion. Come from behind. Push down on my hands. Elbow extension or triceps. Externally rotate. Resist as I push in. for the infraspinatus. Move on to the wrist.
Straighten your elbow, straighten your fingers, put your hand to the side.
Hold the deviation to test for the ECU.
Lean forward, rest your forearms on your legs, extend your wrists.
Wrist extension,
Resist
primarily
as I push
ECRB, ECRL.
Turn over, flex your fingers, flex your wrists.
You want to focus over the second metacarpal to test primarily the FCR. Move on to the hand. You start with the extrinsics.
Wrist in slight flexion. Isolate the IP joint. Resist as I push up. Wrist still in slight flexion. Flex fingers. Resist with your index finger.
So you want to keep the wrist in slight flexion to not get a tenodesis effect. And the final position, hand intrinsics.
Put your hand flat. Put your thumb up straight. Resist as I push down.
Testing the APB, distal median nerve.
Little finger to the side, AB ducted. And resist as I push in.
And testing the ADM. So for the muscle testing exam, some of the key points to think about is to always do bilateral testing to compare strength between the right and the left side. Be consistent in doing your tests. So in order to learn how to do this exam and to pick up on subtle differences, make sure that you do the exam the same way every single time: shoulder, elbow, wrist, hand. Isolate the muscle that you want to be examined, for instance, the IP joint or the FP2. Work the patient. You can't be soft. You really have to push, especially when it comes to the larger muscles, for instance, around the shoulder or the elbow. Testing the biceps in a manual worker, for instance, you really have to push it right in there. And finally, expect nerve conduction studies to be negative. So what are some of the limitations in muscle testing and relative contraindications? Well, the first one is an uncooperative patient. If your patient is not interested in taking part in performing this muscle exam, it's a waste of time and it's not going to be worth it. If you have a patient with a very severe cervical spine disorder, then they are going to have a motor exam that is not going to be normal. And finally, if you have patients with bilateral problems, because it's really is dependent on testing for weakness and comparing it to the other side. Let's move on to the scratch test. And the scratch test is, by all means, rather controversial, but very fun to do once you get the hang of it. The scratch collapse test was first described by Susan McKinnon and her co-workers in 2008. It involves a physical irritant or a scratch of the suspected area of injury or nerve compression. If it is positive, the result is a temporary loss of voluntary muscle contraction. So what is the theory behind the scratch collapse test? Well, there are several. One of the theories is what's called the cutaneous silent period. The cutaneous silent period is a period of inhibition in tonic voluntary muscle activity due to painful cutaneous stimulus. And this is actually something that you can see on an EMG. So if you have an EMG of a person with a carpal tunnel syndrome and you perform some sort of painful cutaneous stimulus, you can see how that EMG signal completely falls away and then comes back. This is mediated by A delta nerve fibers and is generally thought as a protective inhibitory spinal reflex that is causing withdrawal of a limb from a painful stimulus. The second theory is the theory of substance P. Substance P is something that exists throughout the body, including the brain, the spinal cord, and the peripheral nerves. It is found that substance P levels may be increased in nerve compressions, including in carpal tunnel syndromes. And what is known is that if you provoke a nerve or provide a noxious stimulus where a nerve is compressed, you will have a boost in the release of substance P, which is indicating that this plays a role in neurogenic inflammation. But one of the last theories is that there is a new cutaneous type of pain nerve fiber that I did not know of until 2 years ago. Abdo and co-workers published their publication in Science in August of 2019. And what they found was that in between the layer of the epidermis and the epidermis, there is a dermal epidermal mesh or a network of specialized Schwann cells. These Schwann cells convey noxious thermal and mechanical stimuli from the skin onto the afferent nerve fibers, transmitting nociceptive information instantaneously to the nerve. And this might be one of the explanations behind the scratch collapse test. So this is how you perform the scratch collapse. This is a patient who is a manual worker. You can see he really is a Viking with a lot of tattoos on his arm. He's got bilateral carpal tunnel syndromes. You have him seated robustly in a chair, arms in line with the body, shoulders adducted, elbows at 90 degrees of flexion, forearm neutral, and you do bilateral testing. So what you do is you test the strength and external rotation, you scratch over the carpal tunnel, and he can no longer resist. And if nothing else, do this because it's so much fun to do with your patients. They're gonna love it because they laugh, they have fun, they feel like you're doing something as a true physician and clinician. Well, when can't you use scratch collapse test? Well, if you have a patient with a brachial plexus injury that involves C5, C6, C7, it's not going to be possible. If you have a patient with a rotator cuff injury, it's going to be difficult, at least to use the external rotation. What I have learned is that you can actually use other muscles instead. So for instance, you can test the strength in the triceps, scratch over the nerve, and then try it again. And then finally, if you have a patient with cognitive issues or who are not cooperating in this, it's not going to work with the scratch collapse test. So what is the role of the scratch collapse test? Well, I think it's very important to emphasize that the scratch test is one of the tools in our clinical toolbox. It certainly is not the only tool, it's one of them. And like any clinical tool, it needs experience in testing. So you need to practice over and over again. And it should never be the only tool. So you have to combine this with doing a muscle exam, with doing other provocative maneuvers as well. So let me give you some examples of what we can find when we do muscle testing. The first position that we test is the pectorals. So arms completely straight, you put your hands in between and you try to push out. Now, why do we start with that? Well, the pectorals are innervated by almost all of the cervical roots, so C5 through T1. That means that the pectorals are almost always going to be strong. If they're not strong, it's either because you have a patient with very severe cervical spine disorders, or you have a patient who is not cooperating. And if the patient is not cooperating when you're doing this, then you might as well forget the rest of the muscle exam because it's not going to give any reliable results. The second step is testing the posterior deltoid. The posterior deltoid is the first muscle that is innervated after the axillary nerve exits the quadrangular space on the back of the shoulder. This is not a common nerve compression. This is something that you can see, for instance, in overhead throwing athletes or in manual workers who work with a hand a lot above their head, for instance, carpenters. You may, of course, also have weakness in the posterior deltoid if you have a patient with a C5 or C6 nerve confliction. The third one is testing the triceps or elbow extension. If you have an isolated weakness in triceps, you may have a nerve compression of the radial nerve as it swings around the proximal humerus. This is called the triangular interval, and for that reason, this type of nerve compression is called the triangular interval syndrome. What you see when you operate on a patient like this is that you will see the radial nerve entering in between the lateral and the long heads of the triceps. And right in that little slit right there is where that nerve will be compressed. Two other types of radial nerve compressions that you may see is a radial nerve compression in the distal upper arm, as well as the radial tunnel syndrome in the proximal forearm. If you have a radial nerve compression in the distal upper arm, this is a compression that is at the lateral intermuscular septum, as the radial nerve goes from the posterior to the anterior compartment of the upper arm. There you will see a weakness in wrist extension, index finger extension, and thumb extension. If you have a radial tunnel syndrome, you will have a weakness in the ECU, but I will get back to that later on. The most important muscle exams that you need to bring into your toolbox are the 4 exams in the hand. Testing weakness in the FPL due to Lacerta syndrome or median nerve compression at the elbow, FTP5 for cubital tunnel syndrome, the APB for carpal tunnel, and the ADM for Guillaume's canal. So when should we be doing these tests? Well, I would advise you to do this in any patient that is complaining of numbness in the arm or hand, upper extremity hand aches or pains, a loss of endurance. This is if you actually ask your patients, they will quite often say, you know, my hand after I work for a little while, it just gets so tired. It's like I just don't have that strength anymore. If they complain of a loss of dexterity, for instance, not being able to open a water bottle or turning their key to a door, or even in patients that have been diagnosed as CRPS. A lot of CRPS patients actually have nerve compressions in their upper extremity or hand, and thus have something that you can treat to relieve them of their upper extremity pain. And even in your clear-cut carpal tunnel cases, if you have a patient that comes in with carpal tunnel syndrome, it's nerve conduction verified, still do your own clinical testing. So what can we expect to find if we start doing the clinical triad for upper extremity nerve compressions? Well, let's look at what's most common of all. So, Carlos, I would like to ask you about nerve compressions at the Pulvertaft Hand Center. So what would you say are the 4 most common nerve compressions, and which one would you say is your nerve compression number 1, no doubt, the one you see the most often?
Number 1 is carpal tunnel syndrome.
And that's what I guessed too, carpal tunnel. And then I would say nerve compression number 2.
That would be cubital tunnel syndrome.
And that I guessed too. And then nerve compression number 3.
That varies actually from consultant to consultant, depending on what patient you see. But what I see a lot is thoracic outlet syndrome.
Okay, I just put question mark there because I didn't know what I was going to hear.
Yeah.
And then nerve compression number 4.
Nerve compression number 4 will probably radial nerve compressions at Wattenberg's point or proximal forearm or a bit higher.
And a question mark there for me too. Excellent. Well, thank you. No doubt with regard to nerve compression number 1, carpal tunnel, and nerve compression number 2, cubital tunnel. Well, I thought it would be a little interesting to look at nerve compressions in my practice because this is something that I see quite often. And I looked at the statistics from June of 2018 until June of 2021. And during that time period, I had performed 494 nerve decompressions. And nerve compression number 1, Carlos, which one do you think it is?
I think it will be carpal tunnel syndrome.
Lacerta syndrome with almost 41%. which is median nerve compression at the elbow. And nerve compression number 2, on the other hand, carpal tunnel.
Wow.
Nerve compression number 3, can you guess that one?
That would be the cubital tunnel.
That's the radial tunnel.
Oh, wow.
Nerve compression number 4, the cubital tunnel. Not a huge difference in percentage between the radial tunnel and the cubital tunnel syndrome. For those of you who are interested, my nerve compression number 5 is the dorsal scapular nerve, with 2.6% of my patients in the past 3 years. So I would like to spend a little time talking about those two that I think Carlos and probably a lot of you thought were different, which is my number 1, the Lacerta syndrome, and my number 3, the radial tunnel syndrome. I'm not going to spend a lot of time talking about carpal tunnel syndrome or cubital tunnel syndrome, because I think that's something you're all very familiar with and use and find regularly. But if you're going to talk about carpal tunnel syndrome, you need to, Lacerta syndrome, you need to mention carpal tunnel syndrome as well. And as you all know, the carpal tunnel syndrome is the most common nerve compression in most hand surgical practices, obviously not mine, as you saw. And more than 200,000 carpal tunnel releases are performed in the United States every year. Reportedly, there is 80 to 90% success rate at carpal tunnel surgery, which means that 10 to 20% is failed surgery. So if you look at carpal tunnel releases in the US, you have between 20 to 40,000 patients who are regarded as failures. Well, Lacerta syndrome is like carpal tunnel syndrome, but for the elbow. At the wrist, you have the carpal ligament, which is a fibrous band compressing the median nerve at the level of the wrist. At the elbow, you have the Lacerta fibrosus, which is also a fibrous band compressing the median nerve at the elbow. This is Professor Don Lalonde, and I don't think he needs an introduction to anyone who's listening here tonight, and he has given me permission to tell his story. Professor Don Lalonde had persistent symptoms after his own carpal tunnel release. Quote, he says, I had positive nerve conduction studies and the classic carpal tunnel syndrome symptoms. He went through his first wide-awake carpal tunnel release in 2006, which made the symptoms better, but still residual numbness of the left long and ring fingers. He had a redo of his carpal tunnel under general anesthesia in 2007 with no difference. 4 years later, in 2011, at the Canadian Society of Hand Therapy meeting in Vancouver, Don meets Elisabet Hagert. We actually met in the bar of the hotel. We were enjoying a pre-dinner cocktail before the faculty went out, and we started talking. And one of the things we started talking about was how we examine for nerve compressions. And what I found then was that Dr. Don Lalonde did not have carpal tunnel syndrome. He had Lacerta syndrome. So how did I diagnose that? Well, using the triad, muscle testing, the scratch test, and looking for pain under the Lacerta fibrosis. So when it comes to the muscle testing at the level of the Lacerta fibrosis, it is all about where the axons are located most closely underneath the Lacerta fibrosis. So for instance, for carpal tunnel syndrome, we all know that the median nerve located under the carpal ligament, the most superficial axons are those to the middle finger. And that's why that is the finger that goes numb first for our patients. Well, if you look at the Lacerta fibrosis, sorry, I have to go back there, you will find that the axons that are most superficial underneath the Lacerta fibrosis are those to the FCR, the FPL, and the FP2. So those are the 3 muscles that you need to examine to look for Lacerta syndrome. So this is my preoperative testing of Professor Don Lalonde.
And again, resist.
And so you will see weak FCR on his left side.
Straighten your fingers.
Always compare with the contralateral side.
Use your thumb. And resist as I push up.
Isolate the
And resist.
IP joint to test the FPL.
Straighten your fingers.
Same on the other side.
Flex your thumb.
Isolate the IP
And
joint.
resist as I push up. And resist. Flex your fingers. Keep your index finger flexed.
Testing the FTP2. And I always test the FTP5 in case there is a cubital tunnel at the same
On
time.
this side, keep your index finger flexed and flex.
And he cannot resist that. And as you will notice, I often test 1, 2, or 3 times because those muscles need to be fired out. So sometimes you will not be weak for that first test, but you will actually get weakness for the second or the third. Pain upon pressure at the edge of the Lacerta's fibrosis, and the Lacerta's fibrosis is very easy to palpate in the medial aspect of the volar elbow crease, and you can feel that yourself. And then finally, the scratch collapse test. So this is the scratch collapse test for Lacerta syndrome, scratching first on the healthy left side. You can see this patient is strong, and then scratching on that right side where he has a Lacerta syndrome and he cannot resist.
And a scratch collapse.
Yeah, scratch collapse.
So you see how much fun you have when you do the scratch test. It's just amazing. So go home and try to do it. So this is what it looks like when I do my Lacerta syndrome releases. I always do them in Walland. And then I always test the muscles before I start doing the surgery.
Can I ask you to please flex your thumb and keep it flexed and resist, resist, and again, and resist. And flex your finger and resist. And again, resist.
So when doing this in Walland, I use 1% lidocaine with epinephrine buffered with bicarbonate, between 20 to 30 cc's, depending on the size of the arm and patient. So quite often 20 cc's will be enough in a female patient and 30 cc's in a male patient. You want to use tumescent subcutaneous infiltration of the lidocaine with epinephrine to cover the area of the Lacerta's fibrosis from the medial elbow crease and in a distal direction. Wait for about 20 to 30 minutes before starting surgery. And this is what the surgical procedure is like.
ABC nerve branches.
So we've done a transverse
And we use
skin
bipolar
incision.
cautery as necessary.
You see there's hardly any bleeding.
The first landmark to find is the fascia over top the pronator teres muscle. It is bluntly dissected, both superficial and deep. And this is the clear shiny layer you can see here. Using blunt scissors, this layer is cut so that the fascia of the biceps aponeurosis can be visualized underneath. Gently cutting and spreading. Here in this photo, the white, thick layer of the biceps aponeurosis can be visualized and is carefully dissected both superficially and deep before cutting, as the median nerve is often right under this layer. In other cases, there's often a layer of muscle superficial to the median nerve, which can be released as well. In this video, we are cutting the aponeurosis.
So the aponeurosis is also the Lacerta's fibrosis.
And our goal is to cut the aponeurosis in its entirety as to release the median nerve, which is entrapped underneath. Afterwards, we palpate the area both proximally and distally along the course of the median nerve to ensure that we have adequate release. And occasionally, we require further release of the aponeurosis or of the FDS sling. The nice thing about doing this procedure wide awake with a cooperative patient is that after we have performed our release, we can test the patient intraoperatively by asking him to again flex the index finger FDP against our resistance. And in this case, the patient has immediate return of his strength. We also test the FPL tendon against resistance.
And this is that same patient that you saw before.
And flex your fingers and resist with your index finger.
And this is immediately after releasing the median nerve at the level of the
Flex your
Lacerta's
thumb again.
fibrosis.
And resist. And resist.
So the power is back on
Perfect.
the table.
Well done.
Keep it flexed.
And this is done immediately post-operatively.
You can't do it. It's just amazing.
And flex your thumb and keep it flexed. Flex your thumb and keep it flexed.
So the nice thing about testing the patient pre-operatively on the operating table immediately after release is that you get the confirmation that you have actually released the nerve enough. Because if that power is not back, either you have a nerve with axonal injury, which we most often don't have, or you have not done the release extensively enough. I have a video on ViewMedi as well as on my YouTube channel. So if you want to look more closely into this procedure, you can see it right there. I did a prospective study in 2013 where I looked at 119 patients that had been operated for Lacerta syndrome. 70 of these completed a 6-month follow-up. And what we could see was that the patients then had a quick dash and work dash around 40 and post-op around 10, which is a statistically significant improvement. So you should look for Lacerta syndrome in patients that have carpal tunnel syndrome or patients that have gone through carpal tunnel release and not gotten better. In any patients who are complaining of loss of dexterity and endurance, when it comes to Lacerta syndrome, most patients will not have numbness, but they will have weakness in their hand. And that weakness is something that comes after working. You should look for this in patients that have work that entails statically pronated forearms and repeated finger motions. So for instance, musicians, computer workers, surgeons have had quite a lot of those, lab techs, dentists who work with the little instruments all day, and athletes, for instance, in this professional bicyclist. And you should always look for Lacerta syndrome in patients with a negative EMG, but obvious hand pain or loss of hand function. But let me move on to the radial tunnel syndrome, because I believe the radial tunnel syndrome is another sort of misdiagnosed and misunderstood nerve compression. The radial tunnel syndrome is very often found in conjunction with or misdiagnosed as a lateral epicondylitis or a tennis elbow. I looked at my patients that I had treated between 2002 and 2008 for radial tunnel syndrome. And what I found was that 95% of these patients had been diagnosed as a lateral epicondylitis. All had failed conservative treatment. In most of them, physiotherapy would actually worsen the symptoms. So this is something that is not true for tennis elbow. If you have a pure tennis elbow or lateral epicondylitis, physiotherapy will give relief and improve their symptoms. But if you have a radial tunnel syndrome and you do those typical lateral epicondylitis exercises, physiotherapy will actually enhance the radial nerve pain. And if you have a patient with a tennis elbow who no longer has pain at activity, but pain at rest and pain at night, then you have to think of a radial tunnel syndrome. So for the clinical diagnosis, once again, muscle testing. The first one is going to be weakness in the ECU. The ECU innervation is the first nerve that branches off at the arcade of Frost, and therefore the first muscle to get weak. This is what it looks like in a patient with left-sided lateral epicondylitis. So arm completely extended, put the wrist in complete ulnar deviation, and have the patient try to resist as you're pushing into radial deviation. A scratch collapse test. So this is the patient that you saw before, and you see how muscular that patient is. It is a carpenter with a 4-year history of pain on the lateral aspect of his proximal forearm. So adducted arms, 90 degrees at the elbows, scratch over the arcata fros, and he can no longer resist as you're pushing him. And finally, pain over the arcata fros. So lateral epicondyle, 3 fingers distal to the lateral epicondyle is where you will find the arcata fros, and you see how painful that is. The radial tunnel syndrome can also be treated using Walland. I will confess that a majority of my patients prefer to have sedation or general anesthesia when it comes to the radial tunnel release. This is because it's quite a deep surgery, so you have to have a patient that is interested in being awake or is willing to cooperate to doing this in Walland. I always use a dorsal approach for my radial tunnels. I start by infiltrating 20 to 30 cc's of lidocaine with epinephrine over the area of where I'm going to do my dorsal incision, so I always draw it out ahead of time. I will then supplement with 10 cc's that I infiltrate over the volar aspect of the arcata fros, and then always prepare to have 10 cc's of lidocaine with epinephrine on the operating table to give additional lidocaine during surgery. So this is how I do my approach. So you see that little cross right there. So that's where I felt the point of maximum tenderness. I do an oblique incision about 3 centimeters or 2 centimeters distal to the lateral epicondyle. Once you get through that subcutaneous tissue, you're going to want to be careful as you get down to the forearm fascia, as you're going to want to look for cutaneous nerves. So you see that little nerve branch right there. Really be gentle with that because that can cause quite painful neuromas. Once you've gone through and located that cutaneous nerve, you will get down to the fascia, and that will be opened. Let's see if my slide will advance. So once you've opened the fascia, you will find 2 muscle bellies. One is a little thinner and flat and on the lateral aspect of the forearm, that is the ECRL. And if you lift that up gently, right underneath, you will see the ECRB. So the ECRL is flat and the ECRB is going to be a little more rounded. At this point, find the clavage between the 2 muscles and then use your finger to do a gentle digital manipulation between those 2 muscles, because then with your finger, you can feel that finger sliding past the ECRB and all the way down to where you will find the posterior interosseous nerve. At this point, you're going to want to add a little extra lidocaine with epinephrine, because now you're quite deep into the forearm and the patient can sometimes feel pain in this area. So add a little extra lidocaine with epi and always talk to your patient. Ask them how they're feeling. Once you've added that lidocaine with epi, you waited a little while, put deeper retractors in and retract. And what you will see is usually first the sensory branch of the radial nerve. And if you follow that in a proximal direction, you can see the bifurcation between the posterior interosseous nerve and the sensory branch of the radial nerve. And once you've found that posterior interosseous nerve, you can follow that right underneath the proximal edge of the supinator, and that is the arcata fros. And so once you found that, gently pick up that proximal edge of the supinator and just gently, gently, gently cut about 1.5 centimeters to 2 centimeters. Be very careful not to pick or push or move against that posterior interosseous nerve too much, because it's a nerve that you don't want to mess around with. And once you have completed your release, if you're doing this in Walland, you can test for ECU power back on the table.
Okay, so what we're going to do now is we're going to have a look at the strength in your hand. And can I ask you to put your hand out to the side like that? Put your hand out to the side. Can I move it? Okay. And then now resist as I push in. Excellent. Do you feel a difference?
Yeah. I have power.
You have power. Do it again. Excellent.
So in a retrospective study where I looked at patients that were operated between 2004 and 2008, 45 patients in total, 88% had scored a RIT score 1, which is good to excellent results following radial tonal release. We did another study between 2012 and 2013 where we had 45 patients released. 29 of these completed a 6-month DASH score follow-up. Pre-op DASH scores were between 40, almost up to 50 for the work DASH, and down to about 10 postoperatively, which is a statistically significant improvement. But I think a lot of you are wondering, how can the power come back immediately on the table? How is that even possible? Well, remember, in a majority of nerve compressions, you will not have an axonal injury to the nerve until later stages. Rather, what you have is alterations in epineural blood flow and in the saltatory conduction. This is what axonal transport looks like in a nerve. You see all those beautiful little sparkles going up and down that nerve? Well, I'd like to liken this to a garden hose. If you have a garden hose and you turn on the water completely, you will have that water flowing through that garden hose. But if you just gently step on the hose, you will still have water flowing through it, but not with the same power and not with the same strength. But as soon as you lift your foot off that garden hose, you will have that water flowing again. Well, it's the same thing with a nerve compression where you do not have an axonal injury. As soon as you release the pressure on the nerve, that axonal transport will be back. So power back is something that you can anticipate to see in all nerve compressions without axonal injury. So for your radial tunnel syndrome, you will have the power back in the ECU after releasing the posterior interosseous nerve at the level of the arcade of Froese. In a cubital tunnel syndrome, you will see preoperative weakness in the FTP to the little finger, but immediately after surgery, that power is back. And in a patient with an ulnar nerve entrapment at Guillaume's canal, you can have either weakness in the ADM or an inability to adduct the little finger. But as soon as you've released that Guillaume's canal, you can see how that patient once again is able to perform AB and adduction. So in conclusion, remember the clinical triad of diagnosis. Always start by performing a muscle exam. If you do not find a weakness, fine. The only thing that's happened is that your patient will have seen you as a physician that takes the time to truly examine his or her patient. Use the scratch test to verify where you believe that level of nerve compression is. And once you've done that, use compression over the nerve to elicit pain or numbness. So pain and or Tinel's test. And like I said before, if you want to add additional provocative maneuvers at this point, you may. I would just like to finish by showing a picture of my dad. This is Professor Carl Göran Hagert. In 2019, he became the pioneer of hand surgery at the IFSSH meeting in Berlin. Well, his picture is up here because no one has taught me as much about nerves and nerve compressions and the importance of truly listening to your patient and taking the time to perform clinical examination as he has. So he is a wonderful dad and a tremendous hand surgeon. So Carlos and the Pulver Taft Hand Center, thank you very, very much for the opportunity to speak here today.